That's better.
Is that better? Okay. I don't know what I did, but something was set weird. It's now set for the same as my system, whatever that means. All right. So can you see the screen? Second thing. So you can hear me, and I don't sound like a chipmunk, and you can see the screen?
We did before, but I think
And then I unshared it, didn't I?
yeah.
All right. Well, we are, uh-oh. I think I shared the wrong screen. I'm sorry. I've actually used Zoom before now, but how about that? Can you see this?
Yep, that's perfect.
You can? The farm animal case studies?
Yep.
All right. So welcome. Thank you for having me. I appreciate it. I've done this now for a few years, and I do have a few new cases to share. I've actually got a plethora of things that we can talk about, and I'll let you guys sort of help guide me as to what you guys might be most interested in. I will open the chat here. Sorry, my phone's dinging. Just so if you have questions, or if to make it a little bit more interactive. Let me see. And maybe if someone wants to just kind of monitor that, if one of you guys want to let me know if there's like major things in there, if I start getting on a roll. Sometimes I'm not looking at the chat as much as I should. So I have a few just kind of introductory slides just to kind of talk a little bit, especially to maybe the first years that have not heard me talk before, a little bit about my background. I think for those that have been multiple years in the club, likely you've heard me say this before, so you can kind of zone out for a few minutes if you want. But I grew up on a farm. I grew up on a beef farm in West Virginia, in the northern panhandle of West Virginia. And this is the farm that I grew up on. Actually, still my parents' farm. We had about 96 acres. And over here, you can see some cattle grazing, some Black Angus, predominantly Black Angus cattle grazing on that far field. Over here, over home, we have hills instead of flat land like we have around here. And here's in a different season, winter time, I guess, so no leaves on the trees, but here's my cows and barns, and there's a neighbor's horses up there on the hill. But I love this and grew up. This is what sort of fueled my passion for veterinary medicine, for agricultural veterinary medicine in specific. And I, as a kid, wanted to go be a vet, and I wanted to move back home and have a farm and of my own, and then also work on farm animals and probably a mixed animal practice, private practice. This was my dream job. I was going to have a truck and with a little vet box in the back, and I was going to drive into the sunset, or if that's a moonset, I'm not sure exactly what that is, but that is what I was going to do. And lo and behold, about my senior year of vet school, I had an internship opportunity that opened up at Ohio State, actually. And I decided, well, it's just a year, right? I can do anything for a year after being in school like my whole life. And so I decided to pursue that opportunity to do that internship. And after about a year of the internship, my advisor asked me and said, hey, I would like you to stay around and do a residency. And for those of you guys that don't know, which I'm assuming actually probably a lot of you don't know, because I had absolutely no idea, even as a senior veterinary student, I had absolutely no idea what an internship and residency was all about. And in human medicine, this is actually somewhat of a requirement before you go out and practice, is that you do a residency. With veterinary medicine, the vast majority of veterinarians, although it's becoming more popular, the vast majority of residents don't do internships and residencies. They finish 4 years of vet school, and then they typically go into practice. And so I, was talking to my advisor, and he said, well, I'd be honored if you'd stay around and do a residency for 4 more years, or 3 more years after that. And I'm like, well, I guess I can do anything for 3 years. I didn't want to be at Ohio State, but or in the hospital. I wanted to be in my own private practice, and I showed him this picture. No, I didn't show him this picture, but I, was thinking, well, okay, what's 4 more years? Well, in that process, I really fell in love with the teaching aspect of things. And I love teaching students. I love watching students kind of get it, if you will. And so that's really what's kept me here. That's sort of what's driven me. And I don't really have any regrets at all as far as staying. Yeah, there's part of me that kind of misses this, kind of misses the sort of dream job of having my own practice. But I can't imagine things working out better for me than what they have. It's exciting. It's really exciting. Every day is different. And I apologize for these really poor quality videos or screenshots, but I didn't take these. These were the ones that I downloaded off the internet. But you might recognize this field. This is the field over by the RPAC, and this is the athletic center. I think this might be like the natatorium or something in the back, and the athletic complex back here. But these are the soccer fields, or where the band practices their marching band stuff. And these are 2 belted Galloway, so the Oreo cookie cows with the black front end, the black rear end, and then this big white belt in the middle. So the belted Galloway is the breed. And these 2 heifers presented to us for foot trims, just routine foot trims, right? And we have heifers come in for routine foot trims, and that's not a problem. We have that come in all the time for that. And so they came in for this. And if you don't know anything about our facilities, we have a loading ramp that we can extend out to a trailer. And that's what for animals that are not halter broke, which these animals were definitely not halter broke. We have this loading ramp that extends out and it docks with the trailer. And I kind of imagine, every time I do it, I play with it and imagine I'm like in an international space station or something, and I'm docking to some other like shuttle or something. And it's kind of nerdy, but anyway, we do that so that the animals can't have nowhere to go except trailer in the barn. And at the time, my office was just right outside the barn. So barn here, an office was there, and I could kind of keep tabs on, what was happening. My office is actually in a further away place now. But anyway, so these 2 belted Galloways come in, and I hear like commotion out in the barn, which was normal, and for animals loading, unloading, and I heard the ramp go, and then I heard kind of some screaming, which sometimes that can be normal too, and I didn't think it wasn't like bloody murder type scream. But, I'm like, it kind of listened, and then it got quiet, and I'm like, oh, yeah, they must, whatever the issue was, they must have fixed the problem and not too worried too much. And I was doing something in my office, and a few minutes later, I'm listening, I'm like, it's too quiet in the barn. I'm going to go see what's going on out there. And so I walk out there, and there's nobody around. No one. And I look down. If you've never been in our facility, it's got a big, long breezeway, hallway. And I look down, I see one person way at the other end of the hall that's like looking out the big open overhead door. And so I walk down there, and I talked to him, and it was one of our anesthesiologists that was there, and he's like, they're gone. I'm like, what are you talking about? They're gone. Where's everybody at? Why is it so like a ghost town in here? And he was looking across, like standing in our parking lot, looking across John Herrick Drive towards the soccer fields. And these 2 heifers escaped our facility and was running across the road and down over across Cannon Drive and made it over to the soccer field. And what had happened was the trailer, and most trailers have a back door that the animals come out of, and they also have a side door that people usually go in and out of, not animals. Well, the animal apparently didn't want to go out the back door into our little docked loading ramp to pretend like they were international space astronauts. And so the owners decided that they would open the side door and go in front of them and chase them out the back. Well, the 2 heifers that had never seen Columbus before, and they just grew up in back town Ohio, they decided that the side door actually looked like a pretty good place to leave their trailer. And so they jumped out of that into our parking lot, and then from our parking lot ran down the road and across. So that was excitement. There's YouTube videos out there of that incident. And here they are. Here's us with, I think that's me right there, in the blue scrubs with soccer, trying to get these soccer nets, soccer goals, and to try to corral these heifers. Just a word to the wise, in case anybody gets into cattle business, soccer nets don't work well for corrals. So just in case someone's giving you some soccer nets and saying, oh, we will repurpose these for livestock corrals, they don't work. So I'm just saying, but we tried down that day. So anyway, it's always an exciting time. I don't know what that was. Maybe it was supposed to be video. Oh, and there is a cow that these were all ones that I downloaded off the internet. This is the heifer running down. I forget. I don't know what road this was. But it's exciting. It's always exciting, and I hope that never happens again. But it's exciting. This is a typical day, or maybe not quite typical. This is busy, but this is one of our large animal operating rooms. Pre-COVID, there's no social distancing here, and no masks either, so you know that it's pre-COVID. But this is multiple surgeries, perhaps the most surgeries we've ever had going on in our surgery suite at the same time. And these were all pig castrations that we were doing, so we just knocked them all out. Here's one pig. There's actually two pigs on this table, and they're oriented so the testicles are away from each other, one on this end, one on this end, and then there's a pig over on this table, and various anesthetists and people kind of monitoring anesthesia. So it's fun. It really is a great time. So with that, I am happy. These are some cases that I have sort of put together, and I can choose my favorites and kind of go through some of these. If you have seen me do these cases before, some of these you're probably already familiar with, and I don't want to bore you with the same ones, but I'm happy to go through. I don't know, I'm looking at the chat. I don't see anyone, or if anyone wants to pipe up and say, or if they just have any questions, I'm happy to answer any before I move on too. So, alpaca. All right. So alpaca dystocia complications in vomiting pig. Okay. Let's do some alpaca dystocia complications. This is a 3-year-old female alpaca. This was actually an alpaca that came into us from a referring vet, which actually is a really good friend of mine, actually used to work at Ohio State, and then went into private practice. And she just gave birth at home, and it was a fairly difficult birth. I'm sorry I don't have any initial pictures here for you to capture your attention. But it was a difficult birth, which is what dystocia means. And the referring vet was assisting. And so she was doing a vaginal palpation, and she was trying to manipulate the fetus. And she noticed that there was a tear, likely one that she created by manipulating the fetus, which is always a risk when you're doing that. You need to be careful, and she was careful, but it's an inherent risk. And she noticed right away that there was a tear in the caudal part of the uterus, just cranial to the cervix. And so I would ask you, what should we do to approach this tear? I mean, we could do anything from, conservative management would be do nothing, but she brought it here. And so does anybody have any ideas? They can maybe put it in the chat of what we would do, how we would approach this. deliver the baby, then assess the injuries. Good. Okay. Yeah. And maybe I didn't give enough information initially, but if the baby wasn't delivered, sure, in that, then assess it. She actually had delivered the baby. And one of the things after you deliver the baby is that you want to check for tears. And on her assessment, she checked for it. And we say tears and spares. So check for tears in the vagina, check for tears in the uterus, and check for spares, meaning another baby, a twin. And alpacas actually twin very infrequently. It's been reported, but it's very infrequent as opposed to other small ruminants like sheep and goats, which is really common. And in cattle, it's pretty common too. And so always check for spares and tears. And she did that, and she found the tear. So the baby was actually already out. And so we could do a hysterectomy. So if we could completely take the uterus out, and if we took the uterus out, that would fix the tear, right? Because we're going to close everything back up. The owners really wanted her for a breeding animal, and so that was an option that was a little bit lower on our list. But certainly, if they wanted her as a pet, that would be something that we could do. Someone said, see exactly how big the tear is. Yeah. And so assessing the tear. How should we access the tear? And so from our palpation, we felt the tear to be about 2 fingers in width. We could get 2, maybe 3 fingers in there. So it wasn't a huge tear, but at least one that was substantial enough that we could fit our fingers in there. So we could do that. We could assess that on palpation. Any other thoughts? Okay, good. Antibiotics to prevent infection, and definitely we will want to monitor her. Alpacas tend to be somewhat sensitive to peritonitis. And that is something that we need to be careful with animals that, in my experience, they don't do as well with vaginal tearing, with uterine tearing as maybe cattle do. And so definitely monitoring them is something that we definitely need to do. That's really, really good. How about does anybody out there, I'm assuming somebody out there wants to suture the tear, maybe? And that's what I wanted to do. I wanted to fix it. The question is, how do we access it? And Fiona said staple the tear by feel. And actually, that's a really good idea. If you could feel it and you could kind of pull it together, potentially getting a stapler in there like a TI-90 or something, or something in there to kind of pull it across and fire a staple cartridge where you couldn't really suture it very well. I think that would be a great thought. Any other thoughts of how we might be able to access it? It's kind of in an area where it was in probably about 6 or 8 inches. We could feel it vaginally when we stuck our hand in there, palpation wise. But it wasn't an area we could see really well. And from an abdominal approach, I was worried that it was too far caudal to actually, again, see very well if we were in the abdomen, because it was kind of still within that pelvis. Laparoscopically, good. Yeah, that's definitely a possibility as well. So we could do laparoscopic surgery. Potentially, there are some biologic adhesives now, like glues, that it kind of help to increase the strength and healing of incisions. Those are really good thoughts. So I'll tell you what we did. It was actually none of those, although some of those are really great ideas. We actually decided to prolapse the uterus. And so when we anesthetized this animal, we reached in as far as we could. And first of all, we got to thinking, we're like, well, animals that have uterine prolapses, where the uterus turns inside out, comes through the cervix and through the vaginal opening, we can actually see most of the uterus, and we can see the area where the tear is reportedly, you know, fell. And so we're like, well, maybe if we can get this uterus prolapse, we usually don't want the uterus prolapse, and usually uterine prolapses are bad, and we try to fix uterine prolapses. But maybe if we can prolapse it temporarily, we can suture it basically from the inside out. And that's what we did. And we were lucky that we did access the tear. So this is the uterus. We anesthetized her, so she was completely relaxed. We reached in as far as we could palpate the uterus, and we pulled it out vaginally. And so this is the uterus here. This is actually the tear here. This is actually the ovary. And so normally with a prolapsed uterus, you would not see the ovary, right? Because the ovary would be on the abdominal side, but the ovary is actually coming through the tear. And that's we see the ovary because there's a tear there, right? And so that's there. And here's another picture of the ovary, and here's the tear, and then here's the mucosal lining of the uterus. And so what we did was we actually started suturing that. We pushed the ovary back through the tear, and we started suturing from the uterine side, and with absorbable suture, so we don't have to take these sutures out. And we got it all sutured up, and so there's the tear all closed. You can't see the uterus, or excuse me, you can't see the ovary now because it's on the other side. And that's and then the final thing that we did was put the uterus back, and so we reduced now we fixed the prolapse. And so the nice thing about this is we were able to suture it, and we didn't have to make any incisions in the abdomen, and it actually worked really well, that approach. And so that's just us reducing it. And this is the Kriya that was running around the surgery room while we were doing the surgery. And so he looks quite inquisitive in this picture, but he was just chilling out, running around. And here's the owner standing on the other side of the window. Well, actually, I don't know if they were, I guess I don't remember the owners being there. That's weird. Anyway, there's definitely people watching us on the other side of the window. It's kind of creepy. We're thinking about it now. I'm not sure who those people were. They might have been the owner that brought it in. But anyway, so that is the alpaca dystocia complications case. I saw in here someone chose my favorite case, and you guys probably have, some of you have heard me talk about this before. And this was a 5-year-old Angus cow that's presented for a fairly long duration of labor. And we got her in the hospital, and we started examining her. And one of the first things that we do after cleaning them up the best we can is we do a vaginal palpation. You can learn so much with animals that are in dystocia from vaginal palpation. And so we palpate her, and the vagina is super tight, right? I mean, it's just, you can't hardly get your arm in, and she's straining. The calf feels really puffy and swollen, and we could not palpate any fetal response by pinching the toes or, you know, trying to elicit a withdrawal reflex. And so this is what it looked like. And so what do you think about just looking at, unfortunately, you can't smell through Zoom, but with just looking at this picture, what do you think is, what can you say about it? Anybody have any thoughts? Ankles look swollen. Yeah, they are swollen. Good. That's definitely true. What about the feet? There's pus. Certainly there is fluid that's not normal. Yeah, that is also true. It's not your normal clear amniotic fluid that's here. The calf's not in the right position. It is a little bit sideways, and so we have different ways that we describe fetal orientations, and we say the 3 P's, and they stand for presentation, position, and posture, right? And so presentation is how the calf is oriented, whether it's front legs and whether it's back legs. And you really can't tell based on this picture whether it's coming out in anterior presentation, meaning coming out front ways, or if it's posterior presentation, which means coming out backwards, right? And you can't really tell that from this picture because these could be front legs, or it could be hind legs, and we don't know yet. But the position refers to how the calf is, whether the calf's right side up or whether it's upside down, or whether it's sideways. And you kind of look at these feet and you're like, huh, I'd like these feet to be a little bit more upright, right? And so it's likely that there's some adjustments that could be made before this calf is delivered. So that's good. We have meconium listed here, and there may be some meconium staining. And meconium, if you don't know what meconium is just that first bowel movement that the baby has. Usually it's after they're born, but in really stressed animals and stressed fetuses, they oftentimes will defecate in utero, and they'll come out with meconium staining, and they kind of look, if you have a white breed calf, which this isn't, but if you have a light colored calf, sometimes they'll come out orange and brown. And likely some of this discoloration is meconium. That's staining the fetal fluid. Breech is a term that we give to posterior presentation calves that actually have their legs, the back legs, retained. We can actually say with this, that's a good thought. We can actually say with this that it's not breeched, because with breeched, it would be coming out butt first instead of feet first. But we don't know for sure if it's coming out posterior presentation. And oftentimes people say breech meaning posterior presentation, and it could be, these could be the back legs that we see. Looking at these feet, these are not normal hooves. In fact, the hooves are gone. This is the fleshy part underneath the hoof. This is if you'd take your fingernail and you'd rip your fingernail off, this is the tissue that would be left underneath there. And sometimes we see this in really long dead fetuses. They basically start rotting on the inside and they start falling apart. Their hair starts falling out, they stink real bad, and their hooves basically fall off. And so this tells me, when I see this, that not only is this calf dead, but it didn't just die. It died probably 24 or 48 hours ago. And that raises a lot of concern, because that raises concern not for the calf. I mean, the calf's done. I'm sorry for their loss as far as the calf goes, but it raises concern from the standpoint that if we have to do a C-section, that we have to be really careful not to get any of that fetal fluid in the cow's abdomen, because that can set her up for really bad peritonitis because it's infected fluid in the uterus. If it's a live, healthy calf, usually a little bit of that fluid spills in the abdomen, not a problem. But this type of uterine environment can be really toxic when it gets into the abdomen. So we worked on this for a while, trying for vaginal delivery, and we were not successful. We pulled and tried to manipulate things, and we could not do it. So we told the owner that, hey, we need to go to C-section with this cow. And the approach that we recommended to give us better exposure of the uterus is more expensive, because it requires the cow being anesthetized and on her back, and we open them up on the midline. And the owners didn't want to pay for that, which is understandable. But they said, no, do your typical standing flank incision where we keep them awake and we just do it standing. And we're like, well, okay, the risk with this is that if we don't get all that uterus out and we spill any of this fluid in the abdomen, she's going to be real sick. And they're like, no, let's take our chances. We're feeling lucky today. I'm like, okay. So I'm glad they were. But anyway, so we, although we recommended ventral midline, which this is ventral midline, and you can just, this is not the cow that we did. Neither one of these are the cow in question, but I'm just using this as a teaching moment, that on ventral midline, you can get a lot of that uterus out. Okay, so this is the uterus right here, and you can pretty much get the whole thing and expose it. And so when we cut into this, we can prevent any uterine fluid from spilling back into the abdomen. This is what we might get, if we're lucky, with a flank incision. So we do a flank incision. This cow here is standing, and you might not be able to tell because she's under a drape, and this cow's under a drape, and you might not tell which one. If I told you one of these cows is standing, one's not, it might have a hard time. But you have to take my word for it. This cow is standing, and we're standing, and we have now pulled this uterus up to the incision, where this is pretty much the entire body of the fetus. This is one leg of the fetus. Actually, it's 1.5 legs. So there's a leg from here, a fetlock in the hand here, and a hock in my hand here. And this is the other foot from the opposite leg that's poking through. But it's basically a leg and a hoof. We just can't get the exteriorization of that uterus with standing surgery. So even though we recommended this is what they elected for. But because of the cost difference, and that's what this side's showing, they elected to do this thing standing. And so we take this cow to surgery, but while we are scrubbing in for the surgical procedure, this cow decides that she wants to lay down. And we're like, great. So now our standing surgery flank is now become a laying down surgery. But we can still do the same approach and still save the client some money. And so this is surgery. And one thing that you may not know is that we do our C-sections on the left side of the abdomen. And the reason that we do them on the left side of the abdomen is because the rumen is on the left and it holds all the intestines in. Whereas if we open them up on the right side, then intestines tend to spill out more. So we open this cow up on the left, and like we always do, and we tried and we tried and we tried to get that uterus up, and unfortunately we just couldn't do it. And that uterus was too far over, and now the rumen was actually inhibiting us from being able to get it up. And so this is cow lying down and transferred. And so we had this great idea. No, not. It was a terrible, in retrospect, in hindsight, it was a terrible idea. But we had this idea that, well, maybe we'll do a rumenotomy and we'll open this rumen up and empty all of the rumen contents in this trash can that we have here for doing such things. It's got a little grate in there and all the liquid drains out, and it's got a little pipe that runs to the drain. It works kind of well for that. But we filled this trash can up with rumen contents, and there were a bunch of rumen contents spilled all over the floor. And this also is not sterile, right? So we want to prevent this from getting into the abdomen and getting on abdominal viscera and things like that too. But we try to keep it as clean. We try to keep it as clean as possible. So we got all this out. Then we close the rumen back down, and we need to clean everything up now. So we need to clean the rumen surface off because it's got all this rumen contents on there. And while we were changing drapes and doing everything else, this cow decided to, then she was down and we had tied her legs down. Here's ropes on her back legs to keep her from kicking us. We tied her legs back to this bar here in the chute that we have. And while we were changing our clothes to get clean again, this is just us evacuating the rumen and trying to get all the rumen contents out. This cow decided that she didn't want to be laying down anymore, and she now wanted to stand up. And so she did that, and because her legs were tied, she then was unsuccessful in standing up, but she did proceed to trip and fall, and not on the side that she was closed on. Her right side would have been a great side for her to fall on, but she decided to fall on her left side. And this structure right here that's pooching out is in fact not her uterus that we were trying to get out for a long period of time. This is her rumen. And now she is dragging her rumen across the floor in the operating room amongst all of this blood and what is rumen contents. And this was the biggest disastrous C-section that I have ever been a part of. So everything is learning experiences, right? And this is certainly was. But anyway, there's other kind of things in retrospect that there's definitely things that we would do different, you know, when we would look at every case, and that's something that I would challenge you as you move forward in your careers to, you know, kind of look at every case as a learning experience and kind of retrospectively kind of go through, well, I mean, you can't change what you've done, of course, but you can always kind of say, well, if I had to do things different, you know, what would we have, what could we have done different? And I, you know, really think in this case, pushing for that anesthetized surgery, because and I have slightly different talking points now with my clients on these animals. The biggest one is that oftentimes these animals, even if we do everything and everything is successful, these animals oftentimes never rebreed back, and they just don't do well post-operatively as far as meeting client expectations. And so that would be a serious conversation that I would have that I probably didn't have previously. But I had some questions here. Look like figures. How come she was not fully sedated? Well, sedation, that's a great question. So sedation in cattle, it comes with risks. And so when we say there's sort of this gradient between light sedation and full general anesthesia, right? And so the general anesthesia part of this is what added to the expense that the owners didn't want to pay for. So we have that. Now, could we have given her some light sedation? Yes, we could have. One of the things with that is that it makes them want to lie down more, and it makes them more uncoordinated and more likely to kind of fall over and things which would be negatives to the surgery, at least initially, how we wanted to go. I am not sure whether we gave this cow some sedation or whether we did it unsedated. I don't remember her being a terrible patient to work on. And oftentimes that will kind of be the determining factor of whether we do you know, whether we do sedation or heavy sedation, light sedation, general anesthesia. I don't think that was her problem. She just decided at the wrong moment that she wanted to stand up. For the flank C-section, yes, it is just local anesthesia. So we oftentimes will give them an epidural as well, but the epidural does not block for the C-section itself. We will give them an epidural to keep them from straining, make them more comfortable during the procedure so they don't feel like they're in active labor. And then the local anesthesia is performed for a regional anesthesia. Oftentimes we do a nerve block, which anesthetizes the whole flank area of the animal, but that's how we do it with flanks. And I actually have some pictures of what a normal flank surgery would look like. And so this is a standing cow. This is a slightly oblique incision. You can actually make these straight up and down, or you can oblique it. But this is a cow that remains standing for the whole surgery. And it's this is what we like to have. And when we make this the approach, this may be the same picture that I showed earlier, but we try to get that uterus with that calf in it up into the incision. We can lock it into the incision, and then when we make our incision, hopefully that leg, once we lock that leg in, then that keeps that uterus from falling back in rapidly. But there's always a little bit of leakage of fetal fluid back into the abdomen. Most of the time that doesn't hurt them, but when that calf's dead and rotten like it was, certainly that's not good. And then once we make that incision, the legs pop out like this, and again, this cow is standing, the legs pop out, and we get some calving chains on it because they're slippery, right? And we need a handle to kind of hold on to, and then we can use that to pull the calf out. And then what we hope to have happen is we hope while they're still in surgery, usually we're closing them up, and the cow's licking the calf off. If it's a beef cow, if it's a dairy cow, then we don't. But and then we hope that this happens shortly thereafter. And these cows are awesome. They bounce back really fast. Sometimes we expect maybe a little too much of them, but they bounce back. This cow just had surgery. She's standing there letting the calf nurse, and this is what we like to see. So this was a successful case. That's other one, not so much. So, and then how did you eventually resolve the situation? Well, with the cow in the previous case, we ended up euthanizing that cow. Unfortunately, it was a bad deal. We had another conversation with the owner and said, listen, this is really bad now. And we ended up putting her down. There was a question as to why we drained the rumen. Great question. Because the rumen was so full that, and it's not like we could have said, you know, oh, this cow's going to have a C-section tomorrow. We're going to fast this animal for 24 hours before we do surgery on it. And oftentimes when we do abdominal surgery, if we're doing an elective surgery, we do fast them, right? We don't do the anesthesia until they've not eaten for at least 12, maybe 24, maybe even longer hours. And with this emergency C-section, she was likely, maybe she wasn't eating as much because she didn't feel good, but we didn't do that. Her rumen was really, really full, and her rumen was in the way of getting the calf out. And so we opened the rumen up and we drained it so it was smaller and it wasn't interfering with our ability to get the fetus out. That's a great question, and I'm sorry if I didn't explain that well the first time. Is an ultrasound done before deciding how to approach the incision? Not usually. An ultrasound can be really useful in determining if the calf is alive or dead, because we can get a fetal heart rate. We don't typically use an ultrasound to determine whether we need to go to C-section or not. It just doesn't provide a lot of useful information. As far as the approach to use, typically with an abdominal ultrasound at that stage of pregnancy, we put the ultrasound on the abdomen and you just see fetus everywhere. And so determining, you know, whether it's going to be ventral midline or flank, and we usually go for left flank almost always when we do flank surgeries because of the rumen. We like the rumen there to kind of hold all the other intestines in. Even if that calf tends to be on the right side of the abdomen, we would still elect to do a left flank surgery, because with a right flank surgery, they have a lot of intestines there that tend to want to pop out. And it's you're fighting all of those, and it's easier to fight one rumen than it is to fight a bunch of intestinal structures. So great question, but no, typically an ultrasound is not done prior to C-sections. All right. What other case? What's next? I think I saw vomiting pig and neurogoat. Let's do this vomiting pig. This is well, I put this together a couple years ago. I think I may have presented this to this group at one time, but this is an interesting case. So also reminds me of things that I could improve on, right? So it's humbling. But this is Sebastian. He was a 2-year-old male pet pig, and he had a history that he was vomiting for about a day. And one of the things that we're always concerned with when you see animals that pigs, and you'll see this in dogs as well, when they vomit, one of the differentials in your mind has to be foreign body. So meaning, did they eat something that they shouldn't have eaten, right? And we talked to the owner about, you know, what could he have gotten into? What could he have eaten? Could something have lodged in his intestines that's now causing an obstruction that is not allowing stuff to go down, and so it's vomiting back up, you know, and they can corn cobs or you know, the carpeting, we see that a lot in pigs, or Tonka trucks or something, you know, something that's not supposed to be there, that doesn't slide down the intestine, or they can't chew up very well, and it gets stuck. And the owner said, nope, there's nothing that he could have gotten into. I'm like, okay. So, well, I already told you my thoughts on it. I don't know if you guys have any other thoughts. You're welcome to chat them in, but I will continue. So we do a physical exam on every animal, and it's a good thing to kind of get a general assessment of the patient. And his physical wasn't too bad. His heart rate was about 100 beats per minute, which a little bit high, but nothing terrible. His respiratory rate was about 30 per minute. He did not have a high fever, maybe a little on the high end of normal for pigs. But he did have on rectal exam, we could palpate. Now you can't on cattle, you put a hand in, right? Like a whole arm in rectally. You get a finger in a little pig like this. And we did a digital rectal exam, and there was some hard feces in his rectum, but nothing that we, that was super abnormal. So what would you guys like to do next? How would you like to approach this? Exploratory. I like that answer. I'm a surgeon, so I like that answer. Could internal parasites cause vomiting? Potentially internal parasites could, depending on how bad they were, for sure. Excellent. So I've got everything from exploratory to blood work to an ultrasound to a barium series. Yes, you certainly could do that. The pigs are monogastric animals, so unlike ruminants like cattle and sheep and goats, these guys have a simple stomach, and barium series are more telling, are more diagnostic in those animals, because you don't have to fill up this huge rumen before it goes downstream. Something internal for sure. Blood work, radiographs. Good. I like all those answers. I think those are all really, really good. You guys are thinking like clinicians. In all of those would be things that we could do. So we did end up doing radiographs. Shannon got the prize for that one. But yeah, we did end up doing radiographs. And this is what we see. So I don't know, does anybody see anything that you kind of think may be indicative of a problem? So yeah, there is a lot of this spongy stuff. I mean, potentially, pigs do get fecal impactions a lot. And usually we see that up here. Here's some feces in the rectum, right? And here's a fecal ball, and here's a fecal ball, and here's a fecal ball. And I think this is just all ingesta that looks like spongy stuff. And there is some gas. There's gas here, and this is normal gas because this is the lungs, right? And there's a bunch of gas in the intestinal structure. So kind of gave us this overall feeling that, something doesn't quite look right, but we don't see anything specific. We don't see like a metallic Tonka truck or something inside the abdomen that we're like, oh, there is the thing, right? And it's sometimes interesting, especially in small animal. We don't see this too much in farm animal, but you see small animals, dogs that have a tendency to eat things. They eat things that show up on radiographs, and it's fun to try to identify based on what the radiograph looks like, what they ate. And so basically what we made the diagnosis on these radiographs was that he was constipated. And so we decided to give him a laxative. The laxative we gave him is Magnalax. It's like, magnesium hydroxide, the chemical in it. It's like Malox. And so it's a gentle laxative. We decided to give it to him and see what happened. Well, over the course of the next 24 hours, he vomited several times. His physical exam was still unremarkable. We did do blood work, so someone else said blood work, good job. And CBC and a profile were both unremarkable. So electrolytes were fairly normal on blood work, and his CBC, white blood cells, were fairly normal. We did notice that he would eat only small amounts, and then he would vomit. He did drink water, and he did not have any feces that he was actively defecating. And we may or may not have, I forget if we did an actual rectal exam on him again to feel if there was any feces still in his rectum as before, but he didn't produce any feces, right? So no feces. So any thoughts now? So we're going to find out Ann answered that Alexandra's question. Do you typically send out radiographs to radiologists to review? Well, luckily at the university, we have radiologists here that work for us. So every radiograph that I take, well, I don't even take them. I have the radiology technicians that take them, and then they get reviewed by a radiologist. So no, it was not a send out, but it was a keep in, and radiologists reviewed them. Can you do an enema for pigs? Absolutely. And so that could be something, if you did a digital rectal exam and you found those feces still in there, certainly you could do an enema. I see Megan said intussusception, big word, good job. It is definitely a differential for this vomiting pig, and was on our list of potential things, actually fairly high on our list of potential things that could be going on. So great. Any other thoughts? Well, we did repeat radiographs. So we took radiographs again just to see what things changed in that time. And the thought was, you know, sometimes just positioning, intestinal loops kind of change, and we might be able to get a better answer. So, and I think these radiographs are more. Oh, I'm slow. These radiographs are more diagnostic. And so what we have here, we have a bunch of intestinal structures here, and they don't look normal. I can't say for sure what is going on with them. But the other thing that we have is we have this structure, which is the stomach, and it is fairly gas-filled, which may or may not be normal, but the big gas-filled structure is, the big gas-filled stomach is not normal, but that in itself is not pathologic. But what we do have is within this gas, and the gas is actually helping us see this now, because we have all this gas here, and then we have this thing that's protruding in the lumen of the stomach. And we're like, huh, what is this suspicious thing? And so we were like, well, I think that is that a head. It's not a head, and it's not an extension cord, although those are always possible things that you could see. And it actually wasn't a twisted stomach. Pigs can get that. And again, that's another differential. Usually with twisted stomachs, they're sicker. GDVs are what we call them. In dogs, big breed dogs get this too sometimes. And so it wasn't what we had, but we're kind of thinking, based on these radiographs, we weren't thinking that, but that was certainly a differential for all the vomiting, for sure. But now we're thinking that there's something in the stomach, and we just don't know what it is. So we decided to scrunchie, could be a scrunchie, kind of looks like it. We decided to scope him. Okay, and so we're like, well, instead of doing an exploratory, let's see if we can scope his stomach, and because it's just got a bunch of air in there. We can pass an endoscope down, right, down the esophagus in there, and we can see what this thing is in there. And so since the stomach's relatively empty, we should be able to see it, right? And so we called the client back, and we told him that we see this thing in the stomach, and recall that this client initially said, nope, he could not have eaten anything. He does not have access, could not have eaten anything. But now he reports that he could have eaten a part of a blanket and a Wendy's spoon. All right, and so we're like, huh. So this went from nothing, absolutely nothing, to part of a blanket, and a Wendy's spoon is now missing. So our new diagnosis is blanket in a pig. Get it? So instead of pig and blanket in a pig. So we did endoscopy on it. And this is what we saw on endoscopy. We got down into the stomach. We're in the stomach here, and we see this. Well, now we can't see it. We just see black. Oh, there it is. We see this. Oh, no, there it went. Thing in the stomach, right? And so we were like, well, that certainly could be a piece of, it's not something that should be there. It's not a biologic part of the pig. And someone mentioned tumor. It certainly could be a tumor, an ulcer. Those are pathologies that happen in the stomach, but that's not what it is. This is a foreign body. And it was stuck in, and where this is us trying to grab it. Oh, we're grabbing it with the scope, and we're trying to pull it. It's actually moved out of the stomach, most of it anyway, and it's actually going down into the intestines. But we're trying to, so we've got our grabber on it right here, and this is apparently where my video ended. We've got our grabber on it, and we're actually trying to pull it back with the scope. Sounds like a good idea, right? Well, we took the scope out, and we only had a small little piece of the blanket, okay? Instead of, we don't know how much is in there, but there was only a small piece of the blanket. And so we were like, there's more to it than that, right? And we could see it on the scope, that at least the part that we could see was more extensive than the part that we pulled out. So we decided to go back in with the scope, right? And we went back in with scope, and this is what we saw when we went back in. It's movie time. I'm sorry, I know I'm running out of time, but I'll wrap it up. So now we're back in, and this looks different this time. And so Haley asked, do you run the risk of tearing things when you are pulling back with the scope, or is that only in the intestines? You certainly could. It's more likely in the intestines, or the esophagus when it comes up, right? As you start dragging the stuff up. So what do you think? I'll play it again starting here, right? And so this is the second attempt at the scope, and it looks different. But as far as we could, when we were doing that, I mean, we were doing everything the same. What do you think? Any thoughts on what we're seeing? Are those ribs? Kind of looks like what you'd imagine, like the inside of the whale to look like in Jonah and the whale, right? I mean, you have these big things that are going. I won't answer that question yet, but that is a good thought. So we also noticed that at this time when we saw this, when we're doing the scope, that the pig started developing some respiratory difficulty, and he was becoming increasingly more difficult to ventilate. So the anesthetists were like, he's not doing as well under anesthesia. So what are your thoughts now? What do you think happened? And yes, who was it? Nicole and Fiona said, yes, those are ribs. Was it aspirated? Well, you mean like the scope? Did we go down the trachea instead of the esophagus? We started down, well, in the pharynx. So I think you guys are on the right track. You have to think about pig anatomy. They have really short necks, and their thoracic inlet, the inlet to their chest, is real close to the back of their throat. And in the process of trying to get the scope to go down the esophagus, he apparently didn't swallow it, and it went through the wall, the fairly thin separation between the back of the pharyngeal area and the chest. And so we were seeing ribs, but we were seeing ribs from the inside. I mean, we're in the chest cavity, right? That we're seeing them. And this is, well, that's the first video. This is heart here. These are great vessels, and those are ribs. And this is lung. Okay, this is lung that's collapsed down. And because we've let a bunch of air in the chest, and that's why it's not ventilating very well. And so we actually took this pig to radiology. This is what we saw. This is actually normal lung that's inflated. This is lung that's collapsed over here on this side, and this is all free air in the chest. Okay, so see the difference between this side of the chest where it's got free air on the left side, and on the left side, as in the left side of the animal, which is the right side of the radiograph, and on the right side of the animal, which is the left side of your screen, this is normal lung. So this is what this should look like, and this lung is all collapsed down. This is the big gas-filled stomach, and look, we still have that thing in there that we were trying to get out. So this pig has pneumothorax, and so now what do we do? How do we fix this? What's the most critical thing to do now? Should we go back in with the scope and try still to get this piece out, or what? What would you do next? Now it transitioned from a GI case to an emergency medicine case, right? So you have to identify the most pertinent problem, and the most pertinent problem now is not the vomiting and the GI obstruction. The most pertinent problem is the collapsed lung, right? Chest tube to reinflate the lung, absolutely. So we put a chest tube in, or if not a chest tube, at least a needle, and draw a bunch of air off of that side of the lung. So thoracocentesis, that we call it. You could do that with a chest tube or a needle with a vacuum on it. And so that's what we did when we fixed the pneumothorax. So now we got both lungs looking normal. But yeah, we still have this thing sitting there, right? So now we allowed this pig to recover from anesthesia, observing it overnight. We didn't give it anything to eat overnight. NPO means nothing per os, meaning nothing orally. And then we also noticed that it didn't vomit overnight, which made us feel a little better, but we knew that this thing was still in its stomach. So the next day, when it was more stable and actually looked pretty good the next day, despite us doing a thoracic exploratory with our scope, which was unintended, we did an exploratory gastrotomy, which someone way up earlier in the chat said that's what they would have done to start with, which in hindsight, that's what we should have done. We found the stomach to be empty, which made us sad because that would have been a real easy place to get a foreign body out of, right? Because we exposed the stomach, we looked at it, and it's like, oh, it's empty. We don't have anything now. Was it surprising? Well, probably shouldn't have been too surprising, because based on this radiograph, I mean, the stomach looks pretty empty with the exception of just this little thing right here. And we already saw it with the scope once, and we saw a little piece of it in the stomach, but then it was going down the intestines as well. And so we had to use palpation skills to kind of palpate and feel the intestines. And we found a bunch of intestines plicated, meaning they were kind of bunched up on themselves. And it was basically, it went down all the way from the duodenum through the jejunum. So we, in our attempts, and someone asked about foreign bodies and pulling them back with the scope, is there likely a chance to rip the things and tear things? Absolutely, especially with intestines. And so you have to be careful with linear and foreign bodies. Pulling them out, you could just kind of saw through that. And in the process of just kind of manipulating these intestines, they were tearing. And so at this point, we made the decision to do a resection and anastomosis. We knew that we needed to cut a section of intestines off and back to normal intestines and splice the rest back together. And to get back to normal tissue, we ended up taking out about 100 centimeters, so of about a meter of intestine. Now, it doesn't look at here because it's all plicated. This is still with all the linear foreign body inside, and it's all bunched up on itself. But once we cut this open and took it out, it's stretched way out. And there was no way we were going to get this out of the scope. But we didn't know, and that's the reason that we did the procedures that we did. We tried to avoid going to surgery. And this, in hindsight, again, look at your cases retrospectively, what could we have done different? We should have done the exploratory right away, because this, we had no idea, even with the radiographs, that this was this extensive. And there's no way we'd have ever gotten out with scope. Here's a little bit of it sticking out, one end of the intestine, right? And this is what it looked like when we took it out. There's the blanket that wasn't a pig, and now it's out of the pig. And here's the intestines here, and it's all, they kind of stretched out beyond the camera lens. So overnight, we did no food. We did give them water overnight, so we can't say NPO, but we gave them food and slowly introduced the food. I did some pain meds, did some metoclopramide for GI motility, and did well. In 3 days post-op, he was doing great. This is his IV catheter that was in pigs. They're hard to put IV catheters in, again, because they don't have very much neck for like jugular catheters that we usually use in large animal. So we usually do ear catheters, ear veins. So we did this, and there's bandage on there. There's a little stent, like a piece, some vet wrap in there, like a roll, holding that on, and we have this little acute extension set, and it's taped back there, so we could access it easily. His appetite improved. ended up removing the IV catheter at like a few days, and then we put a bandage on his ear, right? It was great. Sounded like a good idea until we noticed later that day that the bandage was gone, and presumably, and we could not find it. It wasn't on his ear. We knew that. And we looked in the stall. We couldn't find it. And we're like, oh no, he ate his bandage.
Dr. Niehaus, I'm not sure if your audio is working. I think it might have turned off.
How about now?
Yeah, now I can hear you.
Oh, I'm sorry. So I forget where it cut off. It did give me a weird error that it was like something changed with the audio. So
it cut off right at he ate the bandage.
Okay. So yeah, so he ate the bandage. Yeah, I can see why that would be a cliffhanger. Yeah, so we were like, oh, he must have eaten the bandage. And so we were scouring the stall, and we were about ready to call the owner and tell the owner that he ate the bandage and we need to take radiographs. And then the student that was on the case that apparently was removed from our conversation said, oh no, I found the bandage. It was in the stall. And I picked it up, threw it away. We're like, oh, thank you. So it was, it made us worry, but it was found. So anyway, it was actually a successful case. It went home. Clients were happy. Pig was doing great, despite complications in surgery, to say the least. So with that, it looks like I'm happy to do another case if you guys want, but I know it's late, and you guys probably have things that you want to do as well. So I already went over my hour. Was this good? What do you think? Is this? Well, you're welcome.
Yeah, thank you so much for coming and talking about all these cases. I don't remember hearing about a bunch of them, so.
Well, good. All right. Well, it was my pleasure. Thank you all. I appreciate it, and I will. I'll stop my screen share, and I guess I'll sign off. So.
Thank you.
Thanks.
You're welcome. You guys all have a great night.
You too.
Thank you.
That was awesome. He went through so much.
Yeah, it was very educational for me.
Yeah, I love how like Zoom is really effective for like interaction, I feel like, because it's not as intimidating as when you have to like raise your hand in the big ass lecture hall, but you can just like type it in the chat and they can address it on their own time, and I love that.
Like you can like go back and address things rather than just like immediately having to answer everyone's questions.
Or being interrupted, yeah. All right, for the rest of the people that's on here, I'm going to stick around for a few more minutes and just answer any questions you guys have or take care of any concerns. But the rest of you are totally free to go.